Hello, my name is Benjamin Lake. Today I'll be presenting on the integrative review. My integrative review was on virtual reality exposure therapy and efficacy in the treatment of PTSD symptoms. The purpose of this integrative review is to examine the efficacy of virtual reality exposure therapy, VRET, compared to classical evidence-based therapy and treatment of PTSD, specifically at 6-month follow-up. Also to explore the research findings in relation to VRET in the treatment of PTSD, and to identify future applications and limitations in the clinical setting. PTSD is a chronic disabling psychiatric disorder that may develop following exposure to traumatic events. The DSM identifies types of events with potential to produce PTSD, which are directly experienced, witnessed, including actual or threatened death, serious injury, sexual violence, and repeat or extreme exposure to traumatic event details. The significance: in the past year, approximately 3.6 U.S. adults experience PTSD, with a higher prevalence of PTSD rates for females than for males. Lifetime prevalence rates of PTSD are at 6.8. Principal symptoms of PTSD present as concern, intrusions about, and avoidance of memories associated with traumatic event itself. VRET exposes patients to immersive virtual situations with increasing intensity and duration, seeking to provoke anxiety response and then weaken or diminish this anxiety response through the habituation process. Supporting theoretical framework used in this integrative review is the title model, which emphasizes an egalitarian relationship within the collaborative and empowering interventions having the potential to facilitate personal growth and discovery, with a primary emphasis on the exploration and development of the lived experience of the patient. This model views life as a metaphor, life as a journey undertaken on an ocean of experience, with all human development, including the experience of illness and death, health, involved discoveries made on the journey across that ocean of experience. So, reporting relevant research and related literature, this integrated review was completed to review adult patients with anxiety-related disorders, specifically PTSD, and the effectiveness of VRET in comparison to the effectiveness of classical evidence-based treatments such as CBT, prolonged exposure, and the effect of symptoms of PTSD within 6-month follow-up. Candidate studies for inclusion in the integrated review were identified through electronic search, which was completed on March and April of 2020. Thousands of reports were identified, however that exact number was not recorded. Original reports including meta-analysis, RCT, and case studies were screened for utilization of VRET. Studies were excluded that did not meet recency criteria of being within the past 5 years, and a total of 17 studies were further reviewed, with 3 being identified for inclusion in the integrated review, including 1 meta-analysis, 1 RCT, and 1 case study. Meta-analysis was completed by Dang et al. They conducted a meta-analysis to review or to investigate the role of VRET as a therapy for patients with PTSD. They had 18 studies focused on PTSD, analyzing the effects of VRET with outcome measures intended to assess PTSD symptoms. Of the 18 studies, 13 were RCTs with a sample size of 654, and 5 were single group trials with a sample size of 60. Participants in the experimental group received 5 to 12 weeks of virtual reality exposure therapy, with participants in the control group receiving either CBT, PE, attention controls, present-centered group therapy, treatment as usual, or the waiting list. Participants in these studies had a primary diagnosis of PTSD according to the DSM and criteria for PTSD based on the CAPS scale. PTSD symptoms were measured as the primary outcome in all studies utilizing the following tools: the CAPS scale, the PTSD checklist, and the Brecht Depression Inventory 2. According to this study, the main effects analysis showed moderate effect size for VRET compared to control conditions on PTSD symptoms. They further identified a dose-response relationship existing, with additional VRET sessions displaying larger effects. Long-range effects of VRET on PTSD symptoms indicated sustained decrease at 3-month follow-up and at 6-month follow-up. Additionally, the single-group trials analysis identified VRET intervention as having a significant effect on PTSD symptoms. Additionally, the RCT, Nora et al. Conducted an RCT of 108 active-duty U.S. Army soldiers examining PE and virtual reality exposure among active duty soldiers within combat-related PTSD. These were all stemming from deployment in Iraq or Afghanistan. Participants, the sample size was 108. They were diagnosed with PTSD using these CAPS, also following the DSM criteria. Inclusion criteria required index trauma to be non-sexual assault occurring at least 3 months prior to assessment in an environment similar to the one currently available in the VRE software. So the participants agreed not to initiate psychotherapy or psychotropic medications during this treatment phase. There was quite an extensive list for exclusion criteria, including changes in medication, psychotic or bipolar disorder, hospitalization within the past 6 months for suicide or self-harm, dual diagnosis, history of seizure, prior PE treatment, ongoing therapy for PTSD, loss of consciousness for greater than 15 minutes, ongoing threatening situation, or an inability to wear the VR headset mounted display. Participants in the control group in the RCT, there was 54. They received 10, 90 to 120 minutes of psychotherapy sessions that were delivered consistent with the published treatment manual for PE. Participants in the experimental group, 54, received identical treatment to the control group except for the use of the VR during the imaginal exposure. PTSD symptoms were measured as a primary outcome utilizing the following tools: self-report survey, Beck Anxiety Inventory, Beck Depression Inventory 2, the self-report civilian version, and the CAPS. According to Noor et al., at post-treatment, VRE participants had CAP scores lower than participants in the PE group, with the effect size of 0.4, 95% CI. Results indicate the patients predicted to see greater reduction rate in PTSD symptoms through the use of VR, were likely to be younger, not taking antidepressants, medications, having greater PTSD hyperarousal symptoms, and were likely to have greater than minimal suicide risk. Finally, the case study. Freeman et al. Conducted a case study where virtual reality was used to augment imaginal exposure in a protocol based on prolonged exposure. So there was a 29-year-old male patient in this case study who developed PTSD following a terrorist attack, where he was a passenger in a bus where a terrorist utilized a bulldozer to run over cars and push the buses over, causing a gas leak. The patient also witnessed someone being decapitated before he assisted several other passengers to safety. Guided by a trained therapist through the use of immersive computer-generated virtual reality, the patient's able to go back to the scene of the traumatic event and help him gain access to his memories of the event, process and reduce the intensity of these memories, fear or anger associated with his pathological memories, and change the unhealthy thought patterns. The computer-generated bus bombings were within a therapist is able to control the severity of the scenario by changing the distress levels. In this particular case study, there was 12 levels, 1 through 12, by having the patient visualize, and also by having the patient visualize various aspects of their lived experience while in the VR over 12 sessions. This method allows greater exposure to traumatic memories while the patient was actively engaged in the virtual environment bus world that desensitizes the patient's anxiety response. So, following the treatment, the patient self-reported. Every day he was able to pass by the scene of the accident at least twice, think of what happened, continue on his way for a week. And for the first time since the attack, he reported he went on the bus where the attack happened, sat on the unsafe side of the bus and said to himself, "I'm doing everything all right." Post-treatments also indicated a large reduction in PTSD symptoms, CAP scale dropping from 79 at pre-treatment to 0 immediately post-treatment. Additionally, at 6-month follow-up, the patient self-reported therapy had helped him in many areas of his life. Also returned to full functioning and passes by the side of the day passes by the side of the attack almost daily. These results suggest further investigation into the use of VR during modified prolonged exposure for PTSD may enhance the rate at which exposure takes effect. Similarities in the studies would include the clinical diagnosis of PTSD using the APA criteria, and VRET having a significant effect in reducing or eliminating PTSD symptoms, and PTSD symptoms being assessed utilizing the CAPS and the BDI. Differences between the studies included the sample size, the number of sessions, methods in providing VRET, and participants, specifically the RCT being active duty soldiers, additionally being mostly male. The meta-analysis design provided the most comprehensive results and would be generalizable to other settings, but did not provide insight into participants' personal experiences. The RCT provided insightful information, but has limited general ability, with only 5 participants being female again. Whereas the case study was very specific and interesting, the design was limited by the sample size of 1 with no generalizability factor. Gaps in the literature would include designs where VRET is used as the only experimental without the patient using their imagination as well. And again, these studies indicate VRET is effective in the treatment of anxiety disorders and may reduce the number of sessions needed to reduce or eliminate PTSD symptoms, which will also reduce cost. Application to evidence-based nursing practice. According to these studies, not only is VRET effective in treatment of anxiety, it may reduce encounters with the patient needed for desired symptom reduction or elimination. These studies also suggest that specifically younger patients would prefer VR technology as a mode of treatment. Another benefit to VRET is that there is no risk of addiction. And looking forward, VRET may be possible through telepsychiatry visits with shared virtual experience guided by a psychiatric mental health nurse practitioner. In conclusion, virtual reality exposure therapy allows tight control over multisensory stimulation presented to the patient, allowing therapeutic strategies to be precisely implemented. VR can simulate situations that can be useful in providing therapy that would otherwise be impractical or impossible to recreate. And VR allows repeated, modifiable treatments that increase emotional engagement and eliminate avoidance in the clinical setting, whereby habituating the patient to their memory of the traumatic event, reducing or eliminating PTSD symptoms, including avoidance. Thank you for your time.